Good evening, everybody. My name is Roxanne Chabot from RBC Consultants. Thank you so much for joining us this evening for our webinar on newborn and infant skincare, update on sensitive skincare and barrier function, what you need to know. This evening, as guest speakers, we have Dr. Lauren Schachner. Dr. Schachner is Stiefel Professor, Chairman Emeritus of Dermatology, Professor of Dermatology and Pediatrics, Director of Pediatric Dermatology, University of Miami School of Medicine. We also have as guest speaker Dr. Peter Leckman. Dr. Leckman is Associate Chief Medical Officer for Primary Care, Medical Director, Primary Care and Pediatrics at Northwestern Medical Group, Instructor of Clinical Pediatrics at Northwestern University Feinberg School of Medicine, and attending physician at the Ann and Robert H. Lurie Children's Hospital in Chicago. We'd also like to thank our sponsor, CeraVe, that has made this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you want to ask a question, you just go to the right-hand side of your screen in the question chat pane and you can type in your question. At the end of this webinar, a survey will be sent to you 1 to 2 days later. If you could please fill it out for us and send it back, we would truly appreciate it. Finally, 1 to 2 days after the webinar, a recording will be sent to you about this webinar as well as a certificate of attendance. Once again, please ask your questions in the question chat pane on the right-hand side of your screen. So without further ado, I will pass the floor virtually to Dr. Lauren Schachner.
Thank you so much for that kind invitation, Ms. Chabot. And Dr. Leckman, always a pleasure to be working with you. I'm really delighted to be doing this webinar this evening. We're going to talk about the very important period of time right after birth that the baby's skin and the stratum corneum, the top level of epidermis, are maturing. It's so important that we do the right things to help the skin mature because the skin is our barrier. And we talk about the barrier function of the epidermis and the stratum corneum. Why a barrier function? Because it's our first line of defense against bacterial infection, against antigens that may be coming through the skin to sensitize an individual to irritants. And also in babies, it's the first line of defense against topical toxins. And that can be prescription, non-prescription, medicine, or non-medicine type agents that wouldn't hurt a 6-year-old or an adult, that can be toxic or even deadly on the skin of a newborn. We can enhance this barrier function, the ability of the stratum corneum, the epidermis to do its protection job for us by maximizing the correct care of children's skin. By using moisturizers, and ceramide-based moisturizers are excellent for this, and for avoiding certain triggering agents such as soaps. So we're going to discuss 8 statements that come from a consensus publication that was done just this past February at the annual Masters of Pediatric Dermatology conference. And it was a consensus about the importance of ceramide-containing skincare for both normal and sensitive skin conditions in newborns and infants. The wonderful group we had together was made up of leading pediatric dermatologists, pediatricians, and basic scientists who, after a day's work, put together a consensus statement. In this consensus statement, 8 issues were stressed. 1, at birth, the skin is structurally and functionally immature. There's elevated skin pH, more alkaline, making it less resistant to chemicals and pathogens. And the maturation process is going to take a couple of years. And the permeability barrier dependent on lipids is very much composed of ceramides as well as free fatty acids and cholesterol that we have to encourage because ceramides are exceedingly important in the hemostasis of the skin, in basic hydration of the skin, and we see in conditions in which ceramides are depleted an increased degree of atopic dermatitis, ichthyosis, seborrheic dermatitis. In other words, if we look chemically at the skin of all our atopic patients, the vast majority would have a deficiency in ceramides. So skincare of newborns has to be safe and effective, and it has to exclude agents can negatively influence the skin. And I often start with soaps when I discuss that, because that can negatively influence a baby's skin, as opposed to more acid-based moisturizing cleanses. They're going to have a pH of like 5 or 6, not of 8 to 10 like soaps will. In terms of atopic dermatitis, which is 20% of the kids in the United States these days, daily use of moisturizer that contain humectants, agents that hold moisture, and ceramides can reduce the rate of flares and even reduce the need for topical steroids. A lot more about that later. Parents and caregivers need anticipatory guidance on how to avoid irritants and triggers, and how to cleanse and hydrate the skin. And Dr. Leckman and I will go over that tonight. Very interestingly, skin care started shortly after birth may avoid skin damage, including known dermatological conditions like atopic dermatitis. In other words, we can prevent it, we believe, in a high percentage of children just by starting off with the correct use of emollients. So the first statement, at birth, the skin is structurally and functionally immature with elevated skin surface pH, lower resistance to chemicals and to pathogens like bacteria. The stratum corneum is not fully developed. It's going to take a number of years before it reaches maturity. At birth and in the first days of life, the skin surface may be as high as 6 on the pH scale. We wanted to acidify it to reach the physiological range, more like 4, 4.5 to 5.5. We've studied newborn skin, and we found that skin surface acidification, lowering the pH, and hydration start taking place shortly after birth. This is a study, and I'll just go over the graph briefly, using electron microscopy to look at how maturely the cells are binding to one another. In babies, it's a very immature, weak bonds. In more mature skin, it's much more highly bound. And we see here that starting at about 6 months, we begin to see some maturation. And it goes on well beyond 20 months to 2 years. And even though at several years the skin is now pretty mature, there still will be a little bit more maturation as time goes on. So very immature, and we have to do everything we can to keep a good barrier function, and moisturizers are a big part of that. So let's look at the scorecard of structural and functional differences between infants and adults. The thickness of the adult stratum corneum and epidermis is a third thicker than babies. So this thinner barrier is going to be less successful, less optimized. The cell attachments and epidermal cellularity, much less in the infant epidermis. The junction between epidermis and dermis, flat, as opposed to thicker and undulating in the more adult population. Lipids, less babies. Melanin, less in babies. Sweat, eccrine production, less in babies. However, baby skin can be a little boggier and have a lower amount of NMF, called natural moisturizing factor. Natural moisturizing factor, again, is like a humectant. It helps optimize the water concentration and hydration level in baby skin, so to give us as an effective barrier as possible. It takes a while for that to develop, and pH, as we've said, is higher. Furthermore, and not very often discussed, the skin's immune and anti-infectious system is immature. It is less active in babyhood than in older kids and adults. And we can actually see a decrease indefensins and cathelicidins, peptides that are essential to fight infection in the skin in babies. So again, we want to maximize the barrier function in every safe way we can, including with the use of moisturizer. The skin microbiome, site-specific, has similar bacteria in adults and kids, but higher in these species in babies. And with maturation, they will even out. So, neonates and infants are susceptible to skin barrier disruption, and hence all those functions we talk about: fighting bacteria, holding out antigens, being able to repel toxins that wouldn't be toxic to you and I, but may be deadly to babies. And this is serious. For those of you who have studied epidemiology in nurseries, you know over 30 children died in a French nursery only because hexachlorophene was added in a small percentage, but inappropriately to topical care. So this can not only have morbidity, it can have mortality. And we'll touch on that later. So newborn and infant skin have increased transepidermal water loss. The state of hydration harder to maintain. The pH can be alkaline, and that can be exacerbated by using soaks. We want to knock our pH down from the newborn 6 to 7 alkalinity to 4.5, 5.5 mature pH. We want to have a full complement of natural moisturizing factor, which will allow for extracellular lamination with lipids. We want to have adequate lipids. We certainly have noted that decreased ceramides are present in inflammatory skin conditions, and we want the skin to help get a full stratum corneum thickness. Second statement, the complete maturation process of neonatal skin takes from 2 to 4 years. And I'm not going to try to make this too heavy on the basic science, but before I hand it over to Dr. Lechman, I want to point out that this maturation process starts during the fetal first trimester, where there are some basal cell layers, but basically the entire skin is covered by a singucellular periderm. That is the sole protection against amniotic fluid and anything else during that initial first trimester. In the second trimester, we see all the layers of the epidermis have been developed. Basal layer, spinous, granular, and very important, stratum corneum, which will be 5 to 6 cell thick. The periderm is then regressed and replaced. Finally, in the last trimester comes one of these real all-stars of fetal skin protection. The vernix caseosa is formed. This waxy substance is formed in collaboration of the baby's skin and mom to give a protective barrier so that babies are not born looking like prudes. Their skin looks waxy, but not too bad looking. The stratum corneum will continue to develop. With that, let's turn it over to Dr.
Hi, everybody, and thank you very much. I'm very happy to be here and excited to join you this evening. I come to this topic as a general pediatrician. I spend my life seeing newborn infants and young children, many of whom have atopic dermatitis, and really have experienced that many parents of these young children really do not have a complete idea of how best to care for their children. So I'm excited to be here to talk about how best to care for children in the neonatal, perinatal period. So, excuse me, we'll back up one slide. So we talked about the stratum corneum. Larry, Dr. Schachner just spoke about the stratum corneum. In utero, the stratum corneum develops. The vernix caseosa progressively covers the fetal skin surface during the last trimester. Its production coincides with terminal differentiation of the epidermis and formation of the stratum corneum. The stratum corneum consists of a hydrophobic lipid matrix with embedded fetal corneocytes, and it possesses unique biomechanics and water binding properties. So this is a picture we all remember when we saw children in the nursery. The vernix caseoma, it's ceramide rich fetal coating, and it forms during the last trimester. The vernix caseosa consists mainly of water-containing corneocytes embedded in a lipid matrix. Free lipids of vernix caseosa show a wide distribution and polarity. And as Dr. Schachner said, the vernix waterproofs the fetus in utero while it's submerged in the amniotic fluid. And the vernix caseosa protects the immature barrier function of the neonatal skin. And the vernix also protects infants after birth. It protects the immature barrier function of the neonatal skin after birth. Previously, and certainly when I was in training and early on in my career, we removed this entirely at birth. And I remember assiduously scrubbing down these babies to make sure they were nice and pink and clean, and we presented them to the mother. But really the trend has changed over the last number of years, and it's allowed to separate over hours to days, with many parents in many nurseries allowing the vernix to remain on the baby for 5 or more days. The vernix layer increases hydration, suppleness, and plasticity of the stratum corneum, and this protective layer decreases the skin surface pH, inhibiting pathologic bacterial growth and also facilitating commensal organism growth. So we move on to our next statement from our consensus paper. And the next statement states that the permeability barrier of the skin is controlled by the intracellular lipid-enriched matrix, which is composed of ceramides, free fatty acids, and cholesterol. So we look at this picture of the skin, or this cartoon of the skin, and we can look at it from different perspectives. So if we look at it starting on the left, at its anatomic layers, at the top there's the stratum corneum, there's the epidermis with the stratum corneum, keratinocytes, and lipids, and then there's the dermis with fibroblasts, collagen fibers, and nerve endings. If we shift to the left of the diagram, we can look at it from a functional perspective, and you can see at the top there are commensal organisms and other microorganisms, and then the stratum corneum, and then below that we have natural moisturizing factor, lipids, human beta defensins, and cathelicidins. And then when we get down to the dermal layer, we have antigen presenting cells, innate lymphoid cells, and memory cells. The physical layer consists of corneocytes, lipids, and keratinocytes, and tight junctions. The stratum corneum is essential for the protective barrier functions of the skin, and the corneocytes are the building blocks of the epidermal barrier. A water-resistant layer of lipid lamellae encases the corneocytes, known as the cornified lipid envelope, preventing water loss and controlling barrier permeability. The cornified lipid envelope and the extracellular mortar-like multi-layered lipid lamellae are crucial elements of the epidermal barrier. So we'll look at the composition of lipids in the vernix and the stratum corneum. Ceramides are a major type of lipid found in the stratum corneum of the skin. After birth, the lipids that constitute the extracellular matrix now have a different and unique composition compared to the intrauterine period. In the ratio of free fatty acids, cholesterol, and ceramides, it's not static in neonatal skin, but it changes as it matures. The ceramide proportion changes from 20% in the vernix to over 33%, between 33% and maybe 50% in the postnatal skin. So the little table that we have here on the left, in the vernix, it's in the 50s for cholesterol, 28% composed of free fatty acids, and 20% ceramides. Whereas in the postnatal stratum corneum, it's in the 25 to 50% cholesterol, 25 to 20% free fatty acids, and 33 to 50% ceramides. So statement 4 from our consensus paper. Ceramides are important lipids found within the stratum corneum, contributing to the intracellular lipid bilayer, essential in the regulation of transepidermal water loss and healthy barrier function. Ceramide depletion is associated with dermatologic problems, for example, atopic dermatitis. So the stratum corneum Extracellular lipids are mainly composed of ceramides, cholesterol, and free fatty acids. There's scary science pictures of those three things. Natural moisturizing factors derived from profilagrin help maintain skin hydration. And ceramides have an essential role in maintaining water permeability, the water permeability barrier function of the skin. So you can have an endogenous decrease in ceramides. So most skin barrier disorders are characterized by a decreased ceramide content. Without the proper ratio of ceramides, the stratum corneum can become incompetent and impair synthesis of cholesterol, ceramides, and fatty acids adversely affect lamellar layer formation, thereby impairing barrier homeostasis, leading to dryness, irritation, erythema, and itching. So there's a study by Kelleher et al. On earlier skin barrier dysfunction in atopic dermatitis. And Kelleher and colleagues evaluated the presence of atopic dermatitis in infants at 6 and 12 months of age using clinical scales. A total of 1,903 infants were included in the study, and 1,300 infants were genotyped for filaggrin mutations. At 6 months, almost 19% of the infants presented with atopic dermatitis, and at 12 months, over 15% with AD. The researchers concluded that the impairment of skin barrier function at birth and at 2 months was known to precede clinical atopic dermatitis. And of note, the same study suggested that increased transepidermal water loss at birth is also a risk factor of food allergy at 2 years of age. We all have heard about the atopic march over the years, and we certainly see this in our practices. The complex pathophysiology of atopic dermatitis translates into a heterogeneous clinical presentation and trajectories of disease progression. Basically, a significant proportion will develop persistent atopic dermatitis and other atopic conditions. Ideally, if we can address atopic dermatitis early on, we can hopefully prevent this progression to persistent wheezing, to rhinitis, and to asthma. And now I'm going to pass this back on to Dr. Schachter.
Thank you, Peter. Statements 6 and 8. Daily use of moisturizers that contain humectants and ceramides reduce the rate of atopic dermatitis flares and reduce the need for topical steroid treatment. Well, that's certainly good news to anyone who takes care of atopic children. If we can decrease the number of flares and reduce the amount of topical steroids, well, we're pretty happy practitioners. And I had started out as a pediatric practitioner, so I'm sensitive to trying to use as little active steroid as possible while maintaining the health of my atopic patients. So if I can use moisturizers and it's part of the everyday care of all atopics, it certainly is positive that we've seen results. And we'll look at some other data and studies ahead. 8, skin care started shortly after birth may avoid skin damaging inducing dermatological conditions, such as atopic dermatitis, that can affect the overall well-being of the pediatric patient. And we heard about the atopic march that can follow. Well, this is a whole nother statement. Here we're saying that there have been studies where we know a child is atopy prone based on the family history or the sibling history or the parent's history, and starting emollient-based therapy shortly after birth can decrease the incidence of atopy. So now we're talking about using emollients not only as a therapy, but as something that might prevent this all too frequent disorder. We'll look at some of this data. For the last 5 or 6 years, all the guideline statements, and this is hard work. I've worked on these guidelines with my colleagues in dermatology and pediatrics. So a lot of thought goes into it. Evidence-based guidelines for atopic dermatitis support the use of moisturizers for skin hydration and atopic dermatitis symptom improvement. So in the Western civilization and industrialized Asia, 20 to 25% of children have some degree of atopy and atopic dermatitis. and moisturizers are indicated as a daily mechanism to improve their symptoms and hopefully would be sufficient on its own for the very mild disease. The guideline recommends moisturizers be used in primary treatment for mild disease and in conjunction with the other agents we have when the disease is moderate to severe. And the other agents, of course, topical steroids, topical calcineurin inhibitors, which are valuable agents and not as dangerous as people have made them out to be some years ago, and topical phosphodiesterase inhibitors as well. Now we have great new agents like antibody-based dupilumab and others on the way, but that's for the extraordinary child. For the management of the mild atopic and for those in moderate to severe flares, always keep the moisturizers and the emollients going. So let's look at this from a whole another point of view, like our friend here is. Moisturizing an atopic dermatitis has in really good research been shown to decrease the steroid use in the atopic child. It reduces pruritus, and using the scores that are accepted by the FDA when new drug applications are done, and those are the EASY score, the SCORAD, and the IGA, recognized scoring systems that clinical researchers chiefly use to evaluate the status of an atopic patient. All three have been shown to be reduced by moisturizing. All right, quality of life is improved. The number of flares annually is reduced, and hence the time to flare in between flares is increased. Now, what we spoke about before, moisturization can play a role, it appears, in several studies in preventing atopic dermatitis in atopic-prone newborns. We'll look at a few studies, and it plays a role in reducing contact dermatitis. And certainly atopics are much more prone to contact dermatitis because if their barrier isn't working well, antigens are more quickly and fully introduced. Protecting neonates from atopic dermatitis. We heard about the vernix caseoso. Do we notice that atopics will not have atopic dermatitis in the nursery or the first days, early weeks of life? What blocks neonates in the first few days of life, infants, from having atopic dermatitis? Well, one of those is an agent that we heard about from Dr. Leckman, and that is vernix caseoso, the original ceramide-containing emollient, first discovered 200,000 years ago, because that's when the human race first began. It's a combination from mom and the fetus to form a waxy, protective, water and lipid-filled layer around the neonate, vernix caseoso. Now, we've had studies looking at children as early as 6 weeks of age who already have cirrhosis and may well be on their way to atopic dermatitis. So oil baths and really gentle moisturizers have been applied in studies with a control group. And in this particular group, 75% of the children who used the combination of moisturizers and oil baths had normal skin at 6 months, compared to 37%, or only half as many, who did not use moisturizers or oil baths. So these seem to reduce cirrhosis and possibly atopic dermatitis. Let's look at some specific study. A few years ago, Eric Simpson and colleagues looked at high-risk infants for atopic dermatitis. What does that mean? It means siblings already born and parents had atopic dermatitis. So this looked at over 120 kids in the United States and the UK. They used a daily emollient for 3 weeks in the treatment group, but not in the non-treatment group. At 6 months, in the group that did not get emollients, 43% of the kids had atopic dermatitis. And this was from statistical prediction of how many would. Only half as many who were predicted to get it got it using emollients. So the relative risk reduction, or the prevention, if you will, was about 50%. This was largely an Anglo population. Another study at about the same time in Asia looked at almost 120 Japanese children. Emollients were started the first week of life. These were kids who were high risk as well. And by 32 weeks, almost 50% of the control group had AD versus about a little less than a third of the emollient group, or if you compare the groups, a reduction of about a third, 33%. So these are two studies out of US and the UK, as well as Asia, in which just the use of a quality emollient in the initial days and weeks of life were able to prevent atopic dermatitis a third to 50% of the times that it was felt that these kids statistically were going to get it. Now, there have been numerous studies since. Several have been very supportive. There have been some that didn't find the same, but the majority seem to be supportive. And emollient use in the neonatal period is something that my atopic families feel has been very beneficial in the next sibling cohort after they've already had atopic children. Statement 5 and 7. Skincare of neonates and infants has to be safe and effective and has to exclude agents that can negatively influence the skin barrier or induce toxicity. We talked a little bit about soap negatively influencing the skin barrier because of alkalinity, but there are a number of agents we'll talk about that wouldn't be toxic to you and me, but can be toxic to a baby. Baby skincare with ceramides mimics physiological lipids and supports natural homeostasis, making for a better barrier and a more resistant barrier to things such as toxins, infections, and antigens. Statement 7, parents and caregivers need to understand how to avoid irritants and triggers, how to appropriately cleanse and hydrate the skin. We have to do some anticipatory guidance with our families, the role of moisturizers and the role of cleansers who are closer to the physiological skin pH of 4 to 6 and that contain emollients, and they're preferable to water alone or soap, which has an alkaline pH 8 to 10. Because of the widespread incidence of atopy, a compromised skin barrier can be the skin that is more susceptible to toxicity. And this may be seen in up to 25% of infants and young children, including atopic kids, ichthyotic kids, kids with seborrheic dermatitis. This increased vulnerability is due to a number of factors. One, babies are globular little people, so they have increased body surface area to weight ratio, and they do not have a fully mature epidermis. Besides this increased surface to weight ratio and immature epidermis, babies seem to have a much higher ability to get transcutaneous exposure to come through the skin. And I'll go over a number of agents. Now, this isn't seen all the time, but neonates and infants, we have to bear in mind, are susceptible to toxicity. These are non-therapeutic and therapeutic topical agents alike. Systemic toxicity may seem to you rare, but just like the newborn is more sensitive to bacterial infection, depending on how much of a transcutaneous product has been absorbed, topical agents that are harmless in adults can cause hematological, respiratory, neurological, cardiovascular, and even mortality in newborns and infants. You may be surprised that agents such as alcohols like isopropanol, anesthetics like benzocaine, insecticides, we talked about hexachlorophene, salicylic acid in high concentrations, all common agents can lead to systemic toxicity, more so in those with skin disease and or impaired skin barrier. So, gentle cleanser and topical applications of physiological lipids can improve permeability barrier homeostasis, keeping in the amount of hydration and lipids we want and not allowing easy passage through the epidermis of toxins, antigens, bacteria. And we've talked about their utility in atopic dermatitis and well baby care management. What should this ideal moisturizer have? What do we want? We want it safe, we want it effective, we want it inexpensive. We don't want additives, we don't want fragrances, and we don't want sensitizing agents within them. It should be pleasant to use both for the parent and for the baby, and it should optimize the lipid and water content of the stratum corneum. With that, we'll turn it back to my colleague, Dr.
Hello. So I'll pick up where Dr. Schachter left off. We'll talk about skincare products for kids. Which are the best products for kids? So we've been talking about ceramides as components of the vernix caseosum and ceramides in the stratum corneum. Well, there are 9 different ceramides labeled ceramides 1 through 9, and CeraVe contains several of these, including 1, 3, and 6-II. So the function of ceramide-containing moisturizer, the lipids that help form, they contain the lipids that help form the skin's barrier. They help skin retain moisture. They help protect the skin against environmental aggressors such as irritants and pollution. You should have formulations that contain ceramides mimic physiologic lipids supporting homeostasis and improving skin condition. And neonates and infants benefit greatly from frequent moisturizer use. So we'll talk about the CeraVe products. And if we look at the different formulations of CeraVe products, all of the formulations have ingredients that are integral to the formulation or that benefit the skin barrier. They all include ceramides, the 3 that we mentioned. They're fragrance-free, they're non-irritating and gentle on the skin, and they're hypoallergenic. Most of the products contain hyaluronic acid. They employ a MVE or multi-vesicular emulsion technology, and they're non-comedogenic. And they limit or do not have parabens, sulfates, endocrine disruptors, dyes, propylene glycol, mineral nut, or coconut oils. So the 2 points to take from this are really the MVE technology, which I'll talk about in a moment, and the inclusion of 3 different ceramides. So CeraVe multivesicular emulsion system is a patented MVE sustained release technology. So looking on the left, MVE is a multi-phase oil and water emulsion system consisting of a series of concentric spheres of oil and water phases. And so it traps ingredients into its oil or water layers and releases them slowly, layer by layer, into the skin over time. The main point of this is that it's a time release system rather than an immediate burst system. So the progressive release of moisturizing ingredients versus quick bursts of traditional emulsion. Here's a little cartoon of traditional emulsion where the product is applied and it immediately absorbs into the skin. Where below, where we're using this MVE technology, you can see that it's a much slower and sustained release of the moisturizer into the skin. So this makes the same point that the MVE system of CeraVe provides slow and sustained release over time versus the rapid burst ingredient release of traditional moisturizers. And again, a cartoon depicting the difference in the rates at which the product is released into the skin. So a study was done by Lindy and Andreessen, published in Cutis, on children and adults with atopic dermatitis. And the point was to evaluate the safety and efficacy of 6 weeks of CeraVe hydrating cleanser, followed by CeraVe moisturizing cream twice a day in 151 subjects. The subjects were basically in 2 categories, children, and there were 33 in that subgroup, and in adults, there were 118, all of whom had mild to moderate atopic dermatitis. And they were evaluated basically 6 weeks after the study began. So here are just some basic characteristics of the group. You can say that there was in the older group. This is the adult group with 118 study participants. So the female predominance. In the child group, there was male predominance. Some of these people had allergies, dairy allergies, hay fever, asthma, and other allergies. And then they had atopic dermatitis in all the usual places. So a cohort study on ceramide-containing cleanser and moisturizer used for atopic dermatitis continues. We'll continue on with this study. And these are just some characteristics or some of the symptoms that people had. So in the group 1, in the larger adult group, the majority were dry, 65% were dry, 15% were very dry, crusting and oozing, with a majority of the crusty oozy people being very crusty and oozy, itching and very itchy. You can see the numbers for the children as well. And basically, if we look at the results, it becomes quite clear. So this is for the adult group, the larger cohort, that there's statistically significant differences in symptoms that patients had after going through this regimen of the cleanser and moisturizer twice a day use. So you can see, itching most of the day, significantly lower, whereas many of these itchy patients reverted to only itching when they were wet, decrease in pain, decrease in irritation, and really the most important thing, an overall improvement in their skin condition. And also the same with quality of life parameters at day 42 on a 5-point scale. And you can see improvement with the left being baseline and the right being after 42 days of the therapy. There's a difference in dryness, difference in very dryness, huge difference in people who are very crusty, itchy, and a huge decrease in atopic dermatitis symptoms. And on the next slide, we see a very similar outcome in the children's group. Even though it's a smaller group, these are patients less than 2 years of age, and we used parent reports to help us, as well as evaluation by dermatologists. But you can see there was an increase, for example, from the very dry patients, statistically significant decrease, crusty patients who suffered from crusty versions of atopic dermatitis, itchiness decreased, etc. So you can see that there's a vast improvement in following this regimen of using ceramide-containing gentle cleanser, followed by ceramide-containing moisturizer twice a day. And these are just some pictures to sort of bring the point home. This is, one of our sad patients that we see every day in our practices with significant atopic dermatitis, on the hands and so forth, popliteal fossa. And you can see the difference in this patient here. So basically, twice daily use of a ceramide-containing cleanser and moisturizer combination substantially improves skin condition and clinical outcomes according to the SCORAD index, as well as the quality of life in patients with atopic dermatitis. And the products were shown to be easy to use and were well tolerated in children and adults with atopic dermatitis, with no adverse reactions reported. So in conclusion, the skin of neonates and infants exhibits distinct anatomical and functional properties that might be clinically reflected by its susceptibility to skin barrier disruption. Infant skin functionally is still developing, as indicated by elevated transepidermal water loss, skin surface pH values, and elevated desquamation. And neonates and infant skin is more fragile and susceptible to infections, chemical, and thermal damage. Skincare for neonates and infants should be safe, effective, and fragrance, as well as sensitizing agent-free. Additionally, the skincare should be pleasant to use, containing ingredients that benefit lipid and water content of the stratum corneum, such as those products containing ceramides. Several studies have shown that skincare, including appropriate cleansers and moisturizers, can reduce the risk of atopic dermatitis in atopic dermatitis-prone newborns. And obviously, more robust studies are needed to confirm the perceived benefits of skincare in neonates and infants. So that's it for our presentation. We'd like to thank everybody for your attention. And I will pass this back to the moderator.
So thank you so much, Dr. Schachner and Lekman, for that very informative and contemporary presentation. Now we're going to pass on to questions. Please submit your questions in the chat pane on the right-hand side of your screen. So we do have a question for Dr. Schachner. What are some of the topical agents that are well tolerated by adult skin but have caused morbidity and mortality in babies?
So we touched on, it's a really important subject. We touched on this during the course of the talk, some of the alcohol products, but even some common products. Let's see. So some of the common products that you probably would be surprised: salicylic acid in topical preparations in too high a concentration has been associated with over 10 deaths that we can find in the American literature. We mentioned hexachlorophene, over 30 deaths in one group in France. Fentanyl patches, over 10 deaths. Even topical Benadryl, there's been associated mortality with overdosing. So the point we want to make is that the neonate can be at risk for agents that would be no problem for a 6-year-old or an adult. But in a 6-day-old, you really have to know what you're putting on the skin. Certainly these emollients that have been approved for newborn and infant skin and have a real history of utilization have a lot of safety, but there are chemicals, even those familiar to us like diphenhydramine or salicylic acid, that can unfortunately be lethal. For those who want to dig a little deeper into this, a paper by CICES, actually out of Northwestern Dermatology, was published just a couple of years ago in the American Journal of Clinical Dermatology, and you can get kind of an exhaustive list of all the agents that have been associated with morbidity and mortality in pediatric skin.
Thank you. Now, could you make a recommendation on treating verruca pedis in infants?
I'm sorry, can you repeat the question for me?
Could you make a recommendation on treating verruca pedis in infants?
It sounds like verruca of the feet, if I'm hearing correctly, VRRICAPEDIS. So yes. If that's what I'm being asked, you can do a number of things. You know, you can kind of watch and wait and be hopeful, because over the course of months and years, the vast majority of verruca will resolve. But if it's cumbersome for the child, then you have to do something to help destroy the lesion. And that can be freezing, curetting, burning, or using topical keratolytics that help dissolve the wart. A lot of it can be home care, like the topical keratolytics. But you just want to go slow and gently, because in most situations it's far from emergent, and you want to slowly get rid of the verruca, not leave a big gaping hole in the foot of a child.
What are some of the structural and functional differences in Asian newborn infant skin barrier that seems to contribute to greater incidence of atopic dermatitis?
You know, it's a very interesting question. And while I can't talk for all of Asia, there was a study out of Thailand which looked at children of more of the indigenous Thai tribal population up in the northern areas, as opposed to a lot of the population which is of Chinese ancestry. And there were, even between those groups, individual differences with increased transepidermal water loss and increased xerosis seen in the more tribal population. So I think the Asian population is fascinating to study, even within the same country, because you can have different genetic groups to look at. So you can't just talk about climate or humidity or ambient. It's really something inherent in the children themselves.
Do daily emollient help newborn infant skin if not preceded by daily bath with gentle cleanser?
Peter, would you like me to take it, or would you like to take it?
No, I'll be glad to take it. Yes, they do. So frequent use of an emollient will always help a child, or a moisturizer will always help a child. There's no reason to, but first of all, the important thing is that you use the word cleanser in that question rather than soap. We do want to stay away from soaps because they can be problematic. And we don't really need to bathe the baby, certainly not every day in all situations. But the frequent application of the emollients in the atopic prone and even the non-atopic prone patients will only help their skin.
Do you have simple guidelines for neonatal sunscreen use? What if they have AD?
Well, again, that's a fascinating question. Peter, is that something you'd like to speak to or the anticipatory guidance, or do you want to throw that one over here?
I'll throw it over to you.
All right. Well, most sunscreens, it can be now agreed that sun protection, which we used to talk about, approved down to 2 years of age, etc. The complete package of sun protection now includes safety in the use down to 6 months of age. And for those products that have been tested in children, they have approvals, they have pediatric labeling on the product themselves. But remember, sun protection and sun screening, while it is an integral part of what we can do for our young people and our infants and children, is only 1/3 of what you should be bringing to your anticipatory guidance to families for their children. One, you don't want babies to have excessive sun exposure at all. So clothing, both for babes and for us, should cover as much skin as possible. It should be lightweight. Cotton is great, but especially for young babies and for very fair-skinned infants and children, you want long sleeves, you want long pants. The less that you have exposed, the less issues you're going to have. Also, teach sun avoidance. It seems like common sense, but as I get older, that seems like more of an uncommon trait. You want your families to do their outdoor thing before 10:30 and after 3:30. In doing that, they can avoid 75% of the ultraviolet light that hits the earth every day. So while there are approved pediatric sunscreens down to 6 months of age, and I think families can pick their own favorite among the major brands and other brands, it's part of a three-pronged attack: appropriate clothing, peak sun avoidance, as well as the use of sunscreens.
Yeah, and just as a general pediatrician, I'll add to that in our anticipatory guidance, and we're almost hesitant to talk about sunscreen use in children at a young age because unfortunately, since common sense is not as common as it should be, we do have people who will, take advantage think they're taking advantage of the sunscreen and put their child into harm's way by putting them, on the beach on a blanket without being entirely shaded, believing that's okay for the baby with immature skin, the baby with very tender skin. So we do really have to dance around that and explain to parents that yes, in a pinch you can, but as Dr. Schachner mentioned, really the best thing is just to stay out when you're very young, and then we can sort of revisit this at 4, maybe 6 months of age.
Just on a personal note, what Dr. Lechman says really resonates with me, because back in my pediatric internship, the first case I had to present at a grand rounds type situation was a baby who was exposed for 2 hours, baby of several weeks of age. That child had severe sunburn and skin burns and every metabolic abnormality you could think of. The problem list ran to the bottom. It was the chalk and blackboard in those days, to the bottom of the blackboard. So this is a very serious issue, and sun avoidance is a really big deal and part of the, as Dr. Lechman said, part of the anticipatory guidance for new parents of babies.
Can the atopic march be halted and or decreased later on in child's life, or only in early infancy?
I don't know that that's been worked out yet. Dr. Schachner?
So I don't have data that speaks to that. I can say that what we're looking at now seems to indicate that if you can appropriately attenuate or even clear the atopic dermatitis in early infancy, it appears that you're going to have a less likelihood of ongoing respiratory or GI sensitivities in atopic populations. Interestingly, some of the newer agents, though we're going to have to take it indication by indication, such as dupilumab, the first of the human antibodies for atopic dermatitis, also is getting some real success used at the same time with other conditions such as asthma, for which you can look at the indications, but even alopecia areata in some kids. So my sense is that with the passage of time and with our increased success in blocking A to B in infants and children, my guess is going to be that data will show we decrease the atopic march.
And finally, does CeraVe line include specialty products for infants and babies?
Peter,
Yes, it does. Yes, it does. So there are very products that are very specific to infants and babies. There's a very comprehensive line of products, and we invite everybody, obviously, to take a look.
and that would include, as Dr. Leckman was saying, again, we gave a list of things that make a product favorable. So I would have you look at that list. But there are cleansers, because we said we wanted to avoid soap, and there are moisturizers, which we've talked about the desirability of within their line. So you can certainly easily take a look at that online, and you can also remember one of the things we talked about was ease of use, but also cost, which is important, and you can see where that's placed. I think it's rather favorable compared to some of the designer products that can be pretty exorbitant.
Well, once again, Dr. Schachner and Dr. Leckman, thank you so much for that very enlightening presentation. And thank you, everybody, for joining us this evening. We really appreciate it. Good night, everyone.
Good night,
Good night.
and thank you.
Thank you all.